Rotator cuff surgery is one of the most common orthopedic surgeries done. It is also one of the most excessively done. I'm going to talk about when it is indicated and when it should not be done.
Before we get into it, for anyone watching for the first time, can you introduce yourself?
Sure. I'm Dr. Leon Popovitz. I'm a board-certified orthopedic surgeon and co-founder of New York Bone and Joint Specialists. I've been in practice for over 20 years. I've been one of the team physicians for the U.S. Open Tennis Championships, and I specialize primarily in sports medicine and in the treatment of the knee and shoulder. My treatment philosophy is preservation is the key to longevity. So surgery is only the absolute last resort, unless it's the only option to preserve that joint.
You said rotator cuff surgery is sometimes overperformed. What do you mean by that?
So rotator cuff tears vary. There are a lot of different types of tears, sizes, and sometimes some of those tears can be treated non-surgically, or at least offered an option of being treated non-surgically. So that's what I mean. I feel like that sometimes some surgeons may be a little bit too aggressive and moving a little too fast into surgery when there are still some non-surgical options available.
What should a patient do if they want a second opinion before committing to surgery?
Find someone that they could trust. Get a second opinion, third opinion, fourth opinion, as many as you need until you feel that sense of security and feel confident in the doctor that you're talking to. But once you start talking to 2 or 3 doctors, it'd be unusual to get 3 different opinions.
What percentage of the rotator cuff tears you see actually need surgery?
I can't, my practice is primarily surgical consults, but so it's different, but it's variable. So it really goes into categories. When younger patients have a rotator cuff tear, it's usually related to some type of trauma, fall, lifting something excessively heavy, something along those lines. The other category is older degenerative, the tears, where people have developed little bone spurs, have repetitive lifting, working overhead activities for all their lives, and eventually it starts wearing and grinding through the tendon, and you get a tear that way. The degenerative ones often can be treated non-surgically. If a conservative treatment works, you can allow it to maintain as long as there's no significant weakness that's developing. For the acute traumatic tears in younger patients, those more often need surgical treatment because those tears, like a piece of paper, will continue to rip and get bigger. And eventually there's atrophy. The tendon starts getting smaller and much of it starts turning into fat. So if you wait too long to fix that, then that may not be repairable, and then you may end up with permanent disability. So you want to make sure that you focus on the right patient and know the right treatment for the type of tear.
What are the 4 muscles, and which one tears most often, and why?
So the four tendons that make up the rotator cuff are the supraspinatus tendon, and that's probably the one so this is the shoulder joint. These are the muscles that attach to the humerus bone. That's our arm bone that we use to raise our arm. And over here, that's the supraspinatus tendon, and it attaches to the top of our arm bone, and it lifts it up above our head. So that probably is the one that gets torn the most, because as time goes on, this bone above it, this acromion bone, may develop little bone spurs, especially with repetitive overhead activities. So whenever we're raising our arm, it'll scrape against that bone spur and grind, and then eventually may cause some tearing through that tendon. Also, when people fall, have an injury, this tendon gets pushed up against this acromion bone, and the acromion bone acts almost like a knife and cuts through it. So more often than not, the supraspinatus tendon will be the one that tears the most. The subscapularis is the biggest rotator cuff tendon. That gets torn less often, but it is more often torn in bigger tears, more symptomatic tears. It is responsible for the internal rotation of our arm or shoulder. A little bit lower here is the teres minor. That and the infraspinatus, which is in the back of that shoulder. It's not shown in the model. They're responsible for internal rotation. The infraspinatus is probably little bit more commonly torn than the subscapularis or the teres minor, but supraspinatus is the one that tears the most.
Does it matter which muscle is torn in terms of severity?
Typically, the subscapularis, if it tears, will cause more significant symptoms.
Is there a tear that is always surgical no matter who the patient is?
It really does depend upon the patient and the circumstances and the type of tear. The acute traumatic tears in younger patients, more often than not, will require surgical intervention, especially if the patient is feeling weakness with it. The more degenerative tears that occur as we get a little older, those very often can be treated non-surgically, but if those present with weakness, then those also may very well need to be repaired. But we often can try some conservative treatment in those cases.
Can a patient tell which muscle is torn from their symptoms?
Well, it depends upon the weakness that they're experiencing, but it may be difficult.
A full thickness rotator cuff on MRI, does that automatically mean surgery?
Not necessarily. So again, if it's an older patient that developed this tear without any history of trauma and has occasional pain or isn't pain, but is not weak, meaning that the other tendons are compensating and allowing the function, those patients can be treated non-surgically and we can monitor to see how they're doing. Even more optimistic would be if it's just a partial tear, meaning that it's not through and through, and it goes through, say, a third of the way or even half of the way, or even 3/4 of the way. If the tendon is not through and through torn, those have a good opportunity to be treated non-surgically as well.
What percentage of full thickness tears do you manage non-operatively?
A lot of it depends upon the age of the patient, level of activity, type of tear, and how it occurred. So if, again, the patient is older and there's no significant weakness, we can monitor and see how things go. If it's a patient in their 30s had a terrible fall and is having dramatic weakness, to be frank, those really need prompt treatment because that patient, God be willing, will be living for 8 more decades, will need the function of their shoulder. And the studies have shown that once the acute tear is fully torn and it's not repaired, especially if there's weakness present, that tendon will start atrophying and retracting and getting smaller and smaller, kind of like a rubber band that pops and then it starts shrinking and shrinking and shrinking. Eventually that tendon starts fading away and there won't be much of anything to repair it. So those need prompt attention.
What does a patient feel with a full thickness tear? Is it always significantly painful and weak?
It very, very commonly is significantly painful. More often they'll feel pain at night. Try to sleep or lay on it. Night pain is very common with a full tear. Not everyone will have significant weakness, no. The human body is amazing. Everybody presents differently. Very often you'll have a large tear of the supraspinatus tendon and the other tendons compensate and it will allow you to function and there's not dramatic weakness. But sometimes there is dramatic weakness. So that we can help more people and reach more people, please be sure to like our video and subscribe to this channel. Thank you so much.